Good evening, everyone. What night is it? It's Monday night, and it's time for Couch Conversations with the Doctors. We just want to say thank all of you guys for being here on this evening with us. So begin to sign in, and we want you to start sharing and creating your watch parties because we are ready for what? Couch Conversations with the Doctors. That's right, Monday nights is Couch Conversations with the Doctors when no question is too big or small, and our doctors are here to try to answer them all for you. So, quickly we're going to go around and do our introductions as we always do. Is this Dr. Everett I see in the back? I think it is. I think he's coming in shortly. Yes, it is. So we're going to go around our table and do our brief introductions as we always do. But I want to say hello to all of our Facebook, Instagram, Periscope family for being here with us, our YouTube family. And remember to share, 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 and share again. I'm going to start with my distinguished co-host, as always, that dad extraordinaire, the guy who believes that he can actually barbecue the best turkey there is. This is Dr. P. So, Dr. P, why don't you introduce yourself to everyone here?
Hey guys, it's a pleasure to be here as usual. I'm the Director of Medical Support Services at Near North Health Service Corporation over the HIV and the MAT program there. It's a pleasure.
Wonderful, wonderful, wonderful. To that family practitioner extraordinaire, that dad extraordinaire, that weight loss guru, the guy who wants to get you all fit and trim and keeps you on a strict diet. I believe his name is Dr. Tony Hampton. Let's say hey to Dr. Tony Hampton.
Absolutely. Excited to be here as usual. I am a regional medical director at Advocate Aurora Healthcare, and I am in the Trinity Advocate Hospital Service area. Very excited about being here tonight, and as usual, looking forward to the good conversation.
Wonderful. To my coworker, who kind of keeps me on target. We bounce off each other, but I love him dearly. That's Douglas Graham. Doug, why don't you introduce yourself to everyone here?
Thanks, Nikki. I'm Doug Graham. I'm a retired physician. I worked in the Chicago area for a number of years. When I retired, I came to Washington, D.C. to work as a congressional fellow in Representative Davis's office. It's great, and I'll try and answer your questions for you.
Wonderful, wonderful. To the man who says that I threaten him to be here all the time, but of course I do not. He's such an extraordinary physician as Dr. James Miller. Dr. Miller, why don't you introduce yourself?
Good evening, everybody. My name is James Miller, and I'm a retired physician, having done clinical practice in the Chicago area for over 40 years, and currently is working in the community to try to, outside of clinical medicine, to help the community improve the general health care in terms of the things that we need to do for ourselves. That's my current goals and project.
To our special guest who came back today to be with us, who is just an extraordinary cardiologist. He's all about the heart, all about the heart. When you go to the hospital, it's all about the heart. And of course, when you're at church, what is it, Deacon Miller? It's all about what's in your heart. So that's Dr. Tim Williams. Dr. Williams.
Thank you for having me. For those of you who weren't here with us last week, I'm Chief of Cardiology at Rush University, and I specialize in cardiac imaging and prevention, predominantly through diet and lifestyle.
Wonderful, wonderful. So I want to say hey to Sean Kennedy, to Michelle Grayson, to Melanie Winston, my good girlfriend who's here with us today. I also want to say hey to Greg Hardy. It is so good to see you here. I miss you. I miss church. I miss my church life. I miss my church life so much. So I miss you guys, and I miss seeing you. And once we can get a vaccine and this is all over with, I'll definitely be there. I see that one of our additional guests just popped in, Steve Robinson. Steve, if you can introduce yourself, that would be great. We don't know what happened. I think we lost you for a second.
Yeah, I don't know either, but I'm back in. I'm Steve Robinson, Executive Director of Northwest Austin Council, community-based organization that's been in existence almost 50 years in 4 years. And it's my pleasure to be here tonight.
So wonderful, and thank you so very much for being here on this evening. I don't know, Pete, do you want to just hop to the questions? Do you want to get started?
Yeah, absolutely. Why don't we just go ahead and get started? There's a caller or a participant that says, "What is multiple myeloma? Is it hereditary, and can it affect my heart?" Anybody?
So I don't want all of you to attack that at one time.
So-
Everybody don't attack it at one time.
Right.
I can talk a little bit about multiple myeloma. It is when one of the cells in your bone marrow grows uncontrollably and starts to replace the other cells in the bone marrow. It can make a lot of proteins, and I guess our circumstances where it makes so much protein begins to deposit in the heart and might affect the way that the heartbeat conducts itself through the region of the heart. That would be a pretty far advanced case.
I'll only add that most of the times it's not inherited. It's pretty much a mutation. And we're very familiar with mutations because we think about COVID. And we've learned about mutations because of that. So a lot of people, now there are some people who probably can get it that way as well, but it's mainly a mutation. And there are some cells called plasma cells. And those cells, they don't really, what they do is they overgrow. Any type of cancer is like things overgrowing. So when they overgrow, they kind of get into your bone marrow and it kind of crowd out the other cells that you need to be healthy. And because they do that, they take up real estate and mess up stuff. So now you have a shortage of cells. Like a lot of people that I've had with this condition have problems with being anemic because now the hemoglobin cells, which deals with your red blood cells, they are diminished, and then you have some people get low platelets for the same reason. So when you think about plasma cells and multiple myeloma, think about cells that shouldn't be hanging out at your house. They taking up real estate that they should be taking up, and then that leads to you being prone to illness. Imagine those infection fighting cells not having that real estate. So now you're more prone to infection. So that's how you want to think about that. But a lot of times you get this and you don't end up being sick because there's different types of myelomas, and most of them are not significant. You know, they have one multiple myeloma of undetermined significance. So you have to work with your clinician to determine if it's something that you should worry about.
And
But I think the part of the question was about the heart.
Yeah.
Right. And so multiple myeloma is one of the conditions that can make a protein, as was discussed earlier, and that protein can actually infiltrate the heart. It's called amyloid. They give it AL is the designation if it's from an overgrowth of plasmacytes that are giving the abnormal protein. And that protein can actually infiltrate the heart and cause a disease called amyloidosis. Now, the reason to bring it up, kind of hijacking the question, Dr. Pete, if you don't mind, is that people in the audience should know that amyloid heart disease is a very serious condition. It can be fatal, and with progressive heart failure. It happens in older people, predominantly men. But the thing that most people don't understand is that much of the amyloid heart disease that we're seeing is actually a gene mutation that is more common in African Americans. And so all of these years, we would have these gentlemen get to be 75 and have what's called diastolic heart failure, meaning the heart doesn't relax well. The walls are thick, and they say, oh, you just didn't take your blood pressure medicines all these years, and you have what's thickening of the heart or left ventricular hypertrophy, when it was actually infiltration. We nowadays have good echocardiographic techniques, wonderful nuclear medicine techniques, so-called PYP scanning or pyrophosphate scanning, and we have cardiac MRI that can identify with a high degree of accuracy before somebody even considers having a biopsy, having somebody go in there and take a little tiny piece of the muscle to prove that they actually have amyloid heart disease. And the reason that this is so important is that we now have therapies. Sure, it's $226,000 a year, but the company actually understands that they could actually be widening the healthcare disparity with pricing like that. And they have promised, no patient left behind. That's their catchphrase. And so if you have someone who has thickening of the heart, they're older, they really should be tested for amyloid heart disease. It's much more common than we used to think it was, because we weren't looking for it. And you never find what you weren't looking for. And so now we have the techniques and we have the therapy to try to treat them.
So, Dr. Kim and Dr. Everett, how often are we doing MRIs as opposed to echocardiograms that we used to do quite frequently?
Are you meaning, can you hear me? Are you meaning for
like diastolic heart failure?
Or just in general? Yeah, I mean, I think we're doing them a lot now. Sorry I was a little late today, but I had some technical difficulties. But I mean, we're doing them a lot. Clearly, we're doing echoes at the same rates we were before. Just about everybody gets an echo sometime in their life if you're in a cardiology practice. But with the availability and the availability of MRI now, we're a lot better at it. There are training programs now that are teaching a lot of our newer physicians and fellows and residents, or fellows and younger attendings, how to read MRI. I think it's we're doing a lot now. So if your physician does ask you to get a cardiac MRI, I think it's probably one of the best tests we have in cardiology. It's just the resolution, the way that so many different things that we could not see before on from other imaging modalities we can see with MRI.
Okay, good. So let's go to the next question. A participant writes, COVID-19 has ran through our family rapidly. We are not having contact with anyone, and my teenage son was just on target for a football scholarship when he was diagnosed with something called myocarditis. If possible, can the doctors please explain what myocarditis is? And because the doctor told me that I really didn't understand what they were saying.
So let me take that one. So this is interesting. And that person isn't in Ohio. They're not an Ohio State Buckeye, right? That's really where the original reports came from, that these very muscular athletes, for reasons that are not clear, tend to have infiltration or infection in the heart. We have known about myocarditis for quite a long time. This typically occurs with a virus, but though we had a set of viruses, cold and flu viruses, that could attack the heart, and a person would go into heart failure, in fact, and you could actually send off the titers and try to figure out what the best therapy for them. Most of the time, you're really just supporting them with what's called vasodilators and beta blockers, technically making sure that you have the coverage to improve the heart failure. Now, the hard thing about that, the best part about it, is that the viral infiltration typically resolves on its own, just like a cold or a flu would. And after a period of time, particularly with the help of the medications, people's heart function goes back to normal. So the real question for COVID is what's happening? I mean, so everybody knows about the lungs, because you see that all over the place. The ventilators, everybody knows about the loss of smell and loss of taste, okay, as it starts to affect the first cranial nerve. But what people are not really thinking about is that it can affect a whole lot of organs, and the testes and the liver, and you can get multiple organs that are involved. And if it actually starts to involve the heart, you could potentially get some heart failure. Now, it's interesting that the data that we just put together out of Rush said that yes, if your function of your heart is poor during COVID, you have a worse outcome. But interestingly, we just had a data set that showed that if your heart was actually overworking, that its function was really high, so-called hyperdynamic, you also had a poor outcome. We have a lot to learn about COVID infection of the heart, and short-term is one thing, but we really need to know what's going to happen long-term. Is it going to be progressive dysfunction down the road and scar tissue formation, or is it going to be total recovery like many of the viral cardiomyopathies? Total recovery, and it's just something that some of those follow-ups, by the way, that have been done on people with documented myocarditis, you do another scan in 2 months and you don't see anything. So it's so far in the athletes, we haven't seen a large amount of scarring. But wait and see. We're in the beginning, not the end.
Wow, that is just amazing to hear. And thank you so much for sharing all of this great information. But just so you know, they're not a Buckeye. They're here from Chicago, and
Okay.
they actually live in our district.
I see.
So she talked about how her and her entire family lives in our district. So, wow.
Nikki, let me comment on kind of a similar topic, but I'm listening to my colleague here talk about the heart and all the bad things that COVID does. And it made me pause and think, okay, so what's the worst thing that'll happen if you get a vaccine, right? Now, they've done a lot of, people have been in this study, 65,000 or so people. So you look at what's the worst thing that'll happen to people from a vaccine. And when you start comparing it to COVID, it just makes you should pause for a moment and ask yourself, so am I going to worry about a sore arm, maybe a fever for a day or two, or the mysterious nature of COVID, and take a chance on that? So I know we want to speak to that a little bit, but I just want to just take a moment for anybody listening. Think about the decisions you're making. You're making decisions to worry about, oh, I don't know about this vaccine. And keep in mind, there's a lot of people who will go through these trials and make sure it's safe before you get to it. In fact, I think the people on this panel, as clinicians, will probably get it before the general public. So we'll test it for you. But then to risk getting COVID and all the things that Dr. Kim is talking about, I just want you to pause before you make that kind of choice, because I guarantee you, I have patients, and my colleagues will say it, 1, 2, 3 months down the road, and they're still sick. I would take a vaccine any day over having that. So I just wanted to put that in the air, because it really breaks my heart when people with limited information, fear, I call it false evidence appearing real, this false fear and these concerns about a vaccine when the disease itself is going to cause the most harm.
Well, I'm gonna be in line with my blouse rolled up to get my vaccine. I'm gonna be in line, probably right behind you all.
I won't have a blouse on, but I'm gonna be in line.
The next question says, does my family history affect my heart health?
Well,
no
question. If I can take, go ahead, Marlon.
Yeah, I mean, no question about it. I mean, family history is probably one of the most important things, and unfortunately, one of the things we as your physician can't change. So we often will try and modify the modifiable things we can. So in other words, if you have high blood pressure, I'm going to be very aggressive because I can't change your parents. I can't change the genes that you were born with. So I'm going to be very aggressive with your blood pressure, with your cholesterol, with your diabetes. But no question, family history. But at the end of the day, I mean, you can't sit there and just say, I hear it all the time. Oh, my mother had this, my mother had high blood pressure, so I'm just going to have it. That isn't quite, isn't the right mentality that we should have. We should really strive to really control the things that we can control and not accept the norm. It's funny because I would say probably, and I'm guessing, 50, 60 years ago, we really did think that a normal blood pressure was 150, 160, okay? And when that happened, those people who continued to have the blood pressures of 150 and 160, they ended up having problems at age 70 and 80. Now, most people are living to 70 and 80, and they don't want to have those problems. So we have, over the years, the target has changed, the goalpost has changed, of course. We've definitely lowered our standards and what we think, because we know that people, the longer you live with these ailments, whether it's high blood pressure, diabetes, or cholesterol, the longer you live, the worse you're going to do. And unfortunately, maybe sometimes one of the best things you can do is die, because you won't have all these symptoms. But unfortunately, interestingly enough, we're all living to 70, 80, and 90, and we're feeling it. And the goal is to grow old and not feel it. That's really the goal.
Right.
No one needs to be sick.
So let me comment a little bit. It's I remember the days when people would say 100 plus your age is what your blood pressure should be. That was so incredibly wrong. The sprint trial that everybody heard, yes, me and the other 16 members of the hypertension guideline group took a lot of flack for redefining blood pressure as 130 over 80 instead of 140, or the rogue JNC 8 that didn't actually get finished, where they were saying it's okay to be 150 over 90 if you're 60 years or older or above. What they weren't taking into account is that strokes are actually higher in the older population, and that everything we had done to lower blood pressure in the older population, it actually reduced the stroke rate, and just accept that as fact. So then the sprint trial came out, which tried to just compare 120 versus 140 and see what happened. And in the elderly population, there was a dramatic decrease in bad outcomes: stroke, mortality, heart failure. And sure, when you go for a lower goal, you do risk a little dizziness. You do risk some transient acute kidney injury if you overdo it and you have to back off a little bit. But in general, it was highly successful sub-analysis that everybody should look at. Sprint elderly, they divided it into 3 different groups: the frail, the not so frail, and the people who were robust above 75. And they all did substantially better with a lower blood pressure target. And so, yes, we should not be accepting of what happened to our family. I try to tell my patients, remember, you're a hybrid, not a clone. Mm. And so you do not have to live out to what happened to your parents. You can make your own way, and by changing your lifestyle.
Wow, great comment. You're a hybrid, not a clone. Okay. I want to say hey to Sister Bonnie. Claiborne Wade, I see you just checked in. Your question was the exact first question that Dr. Pete gave to the panel and that they began to discuss. So if you missed it, I'm sorry, but go right back to the beginning and hear it so you can get those answers you were looking for. Sean Kennedy says, OMG, did I just hear what I heard? I don't know what you heard, but when you replay it, I know you were here. Linda Johnson says, good evening. And once again, Bonnie says, wow. So this is great information that they are sharing with you on tonight. You know, our next participant, her name is Janice, and she says, hello, everyone, I'm Janice. I'm 34, and right now I have bad anemia due to fibroids. The doctor had me taking blood and iron, but I've developed a heart murmur. They say it's because of the anemia. What exactly is a heart murmur? Why did this happen? Will it go away? And is there anything I can do?
Yeah, so it's really important to recognize that your body is so smart. The incredible design of the human body, we just have to marvel at it. And so how do you get oxygen to tissue if you don't have blood cells, if you don't have enough blood cells? And so if you're anemic, what you're missing is the ability to carry oxygen to all your tissues, and your body responds to that by, first of all, increasing its volume, okay? And then that it gives you sort of a higher cardiac output. So you just keep sending those same few blood cells that you have around and around back to your lungs, get some more oxygen, and then go, rinse and repeat, do it over and over again. That so-called high output state can result in actually so-called high output heart failure. People will swell, and people will actually have sort of volume overload. And because of the higher output, you could have a very normal valve. Where's my? You could have a very normal valve, okay? And you're putting, 1.5 or twice as much blood through that same valve. It's going to make a murmur, and so that murmur is a very normal kind of thing that happens when the blood count is very low and you've done the volume expansion. So what do you have to do? Get the anemia fixed. Okay, it works really good. But you have to pipe up here. One of the things that we have to be careful about is people using animal products to get a quick fix, because the iron, when you're doing animal products, is oxidized iron, so-called heme iron, which is really well absorbed, and it's really can fix things fast. But unfortunately, it can cost, according to the NHAAP study, it can cost the development of coronary heart disease and can actually result in more plaque, unstable plaque. So staying away from heme iron as much as you can. So you just, go to your search engine, find what are all the vegan sources of iron, so you can just I would just chomp on them all day and all night, because vegetable iron is not absorbed as fast. You have to do more of it, but at least you're going to protect your heart.
All
Yeah.
right. Well,
I have no, I was just going to comment. I agree with Dr. Williams and everything about the anemia and murmurs. And one of the questions we often get are, what are murmurs? And essentially, it's a sound that your heart that we hear when we're listening to your heart. Now, murmurs, essentially what happens is you have basically, for lack of a better word, French doors that let blood into your heart and let blood out. And those French doors can either not open well or not close well. And so essentially what happens is your blood can either not get out of your heart well, or not get or come back into your heart instead of going out into your body. So those murmurs are very, very common. And we do a lot of diagnostic tests. You end up seeing your cardiologist. See, but at the end of the day, we really do. They're real, and they often are related to the heart valves. And we have a lot of good treatments that can help it. Most people with murmurs do not need treatment. That's just the reality. I hear the comment all the time. I've had a murmur since I was a kid. There's a different murmur when you're 14 as opposed to 65. It's just a different murmur. So I think that if you do have a murmur, which many people do, don't get too crazy about it, but end up talking to your doctor about it. We have a number of tests that can tell you exactly if it's a bad murmur, a good murmur, one that can be dangerous, one that can be fixed, not be fixed, and we can take it from there. So that's essentially what a murmur is.
All right, great. Should we take a stress test yearly?
A great question. That's a great question.
So take it to, yes, since I did stress testing for a living for almost all of my career. So, I mean, we had this whole thing, and it wasn't just doctors trying to make a lot of extra money. It was a lot of what we call defensive medicine, where if somebody had a heart attack because, they had all you need is a sudden rise in your cholesterol, and you can break a cholesterol plaque. And so all you have to do is look at the med legal history, and you find doctors who were sued because they hadn't done a stress test in the previous year. And so it became habit, and I when I was at University of Chicago and Marlon was there were a couple of doctors who actually wanted stress tests. If you had bypass surgery, you had to have a stress test every 6 months. Well, you know what? That got out of control. And it wasn't value added. It was a lot of expense, and it wasn't necessarily going to prevent an event. It was just going to tell you, if somebody was developing without any symptoms, which it does happen on occasion, but it's relatively rare, developing a re-narrowing of their arteries and the like. And so we pretty much all at the same time, when unfortunately I happened to be coming in as president of the American Society of Nuclear Cardiology. And all of a sudden there was a bullseye on our back because they announced that nuclear stress testing was the #1 Medicare expenditure. That's not a good place to be. There was a lot of overuse back then. That was about 2004, 2005. And everything really happened at once. We had these insurance companies hiring so-called radiology benefit managers. You had Congress passing laws and Medicare passing regulations about restricting the stress tests. And so nobody really should be getting annual stress tests, to answer that, unless they're having new symptoms. We did at the same time that all this stuff was going on with legislation and regulation, we did try to police ourselves. American Society of Nuclear Cardiology and the American College of Cardiology got together and we wrote so-called appropriate use criteria. Now, there are some other organizations that wrote up their own criteria as well, but the final summary would be that if you have known disease, and particularly after bypass surgery, you should have a stress test, but it should be every 5 years at the narrowest. And you may not even need it then if you have no symptoms and you have a great functional status, you're running up mountains and everything, you probably don't need one. After a stent, we actually and this was done by a voting process. So you could say that it's not the most rigorous because it was consensus of experts, really not a lot of data. But after a stent in a coronary artery to prop it open, we think it's reasonable to do one every 2 years if you want it. But there aren't any conditions that we know of that would make you have a stress test for coronary heart disease. Now, there are a few outliers like, when your heart is overgrown, a genetic abnormality called hypertrophic cardiomyopathy. People think they don't know what that is, but they remember Loyola Marymount and Hank Gathers and having a cardiac arrest on the floor going up for a rebound. That particular disease, it would be reasonable, or other rhythm conditions, not looking for blood flow differences, looking for rhythm disturbances, and making sure that a person is not developing some serious life-threatening rhythm disturbance at a high level of exercise. So there are some exceptions to it, but for the general population, doing a stress test for coronary heart disease is something that we really should do according to our appropriate use criteria.
Yeah, I have a follow-up to this, guys. Mm-hmm. Should everyone be on a statin or anti-cholesterol medication?
Okay, so I got to take that one, Marlon. So this is what I get all the time. As the vegan cardiologist, I get a lot of people coming to me because they don't want to take a statin. And I immediately go to the search engine and I type in 2 words. I actually put in statin and mortality. And I let them look at the results on imaging. And what they'll see is these Kaplan-Meier plots. Okay, where I like this. This is what happens, your survival when you take a statin, and this is what happens when you don't, if you have a condition that really requires it. And then I'll show them the statin taker data versus the statin stopper data. They show you that the high dose is better than the moderate dose, moderate better than low, and low is better than none. But it depends on what the condition is. Now, the funny thing about this is that once we have the risk calculator that I mentioned last week, we actually found out that there are some people with a high cholesterol, but they have all of their other risk factors are actually low, that we actually took them off of statins because we stopped treating cholesterol and started treating risk. And so that is really where the field has gone. Now, today is the 7th, the day that'll live in infamy. Tomorrow, it'll be even more infamy when there'll be 2 publications that came out talking specifically about how we had LDL cholesterol wrong for the last 40, 50, 60 years. Oh my God. Last year and the year before, we found out that the HDL stuff was wrong. It's bad when it's low and it's bad when it's high. They both cause heart attacks. Well, now we're going to find out that the IDL, the one that we ignore, that was what the I stands for, the ignore density lipoprotein, the intermediate density lipoprotein, and the VLDL, very low density lipoprotein, may be more important than LDL. And all the time that we've been giving these statins, lowering the LDL, we're actually lowering other things as well, other components that may actually in some populations be more important. So you'll hear this all over the news on Tuesday, December 8th, that's tomorrow. And, it's going to send, shockwaves through the community of how we're treating patients, and our guidelines will have to get updated. We're going to have a calculator that stops overvaluing high happy cholesterol that's not so happy if it's really high. And we're going to have to reincorporate IDL and VLDL. So basically it's a mess. Everybody needs to be on a whole food, plant-based diet and doing exercise every day. If you're a thin walking vegetarian, your lipids may not be quite as important. I can't utter that whole paragraph without mentioning inflammation as well, which is another, I know we talked about it some last week, but the inflammatory markers are important as well. So it's not just cholesterol by itself.
Yeah, I agree. I'm going to go back to the stress test question. I'm going to leave the statin alone because that's a tough one. But I will touch a little bit about that. But in terms of the stress test, I think that it's very important for us. There's really no need in my mind to do a stress test on an annual or biannual basis or anything like that. You should really be stressing yourself all the time. In other words, if you tell me that, look, I used to be able to walk for 45 minutes 5 times a week, now I can walk for 20 minutes. 3 times a week and I get tired. Or I used to be able to walk and walk up and down the aisle to the grocery store for an hour and shop the entire time, but yet now I have to stop and sit down and relax. So those are the type of things we really need to promote. Activity. You need to keep moving. That is your stress test. You will know. Most of us know our bodies, and you know what? You used to be able to walk 3 blocks without a problem, and now you're stopping twice on the way to walk 3 blocks. That's usually a failed stress test that did cost $3,000. That's just the reality. So I think that's one of them. In terms of the statin issue, I talked about earlier about how we can't really control. We really can't control family history, but there are some things we can control. And really, from a medication standpoint, I know that vegans and vegetarians will say something. There are not too many things that we have in this world that will actually get rid of plaque. But statins are one. Now, there's a lot of diets that definitely, I do believe, definitely helps and helps with reduction of plaque. If you have plaque in your artery, which many of us do, there's not too many things. There's certain liquid plumber pills that we can take to just get rid of that plaque. And so cholesterol medicines or statin medications are one of them. So I wouldn't think of it as a bad thing just because of medicine. I think we need to just change our mind frame. It is actually a very, very good medicine. And many patients should be on statin medication, in my opinion.
Can I do a quick follow-up on that? So I agree completely with Dr. Everett, and the statins have to be valued because of their big impact. And I always joke that they are the reason that the Medicare Trust Fund is going broke, is because people are not well and they're not dead. And so if you're the insurer, that's a problem. Okay, so the statins, and there are really only 2 out of the 7 statins that have plaque regression data. That's the atorvastatin and rosuvastatin. There's the Ornish diet, the Esselstyn diet, and then most recently the Glagoff trial, the evolocumab. It's one of the PCSK9 inhibitors. So those are our 5 things, and of course we don't use rosuvastatin and we don't use the 2 statins together. So you really have 3 different categories, and we look forward to more data. And they all revolve around the same idea, and that is getting our LDL cholesterol down to about 55 or less. If we do that, which is our newest target, we can get the plaque to start to go away.
Okay, so now we have to add the I. We got to remember to add the I. I'm stuck. I'm always concerned about, is my LDL right? Is my HDL right? Now I got to add the I's. And I know other people that they got to add an I too. But it's all about being healthy, and that's what's necessary. So we're going to wait around to make sure it all gets figured out and that our I's are on target and that we have the I. Can you explain the Watchman device, and is it a good therapy?
Yeah.
I think it's Victor and Marlon. We're tag teaming here.
Okay, so it turns out we kind of touched base on
questions from last week when I told you we were giving this abundance of questions. So yeah, these are a lot of the ones from last week. So I see some of you typing in some questions here this week just as well, but I'm trying to catch up with your questions from last week so we can get that done. So yeah, I'm sorry.
So let me just try. Yeah, so we did touch base. So I'm going to try and give a little overview again about what exactly. So atrial fibrillation is the irregular heart rhythm that you hear about on television all the time, and essentially what happens is in one of the small little pockets inside the chamber in the heart, you can develop a blood clot. Now, if the blood clot stays in the heart, it's really not a big deal. But unfortunately, the blood clot doesn't like to stay in the heart. It likes to leave the heart. And when it leaves the heart, it can go anywhere in the body. It can go to your brain and cause a stroke. It can go to your limbs or feet and cause gangrene. It can go to your kidneys and cause kidney failure. So short of cutting open your chest every week and trying to pull out the blood clot, what do we often do? We give you a blood thinner so you don't develop the blood clot. Unfortunately, many people cannot tolerate blood thinners. And it's for a number of reasons, but usually it's a reason such as they're bleeding and they're internally, and we just can't find it. You know, when we do our scopes to see where you're bleeding, we look at the top half of the GI system, and we look at the bottom, the top portion, maybe top quarter at best of the GI system, and we look at the bottom quarter. But there's still 7 feet of intestines that we cannot get to and can't see, where you can actually be bleeding from, and we just can't stop it. So there are a number of people who just cannot be on blood thinners. That being said, in that small chamber in the heart, you still can develop a blood clot if you're not on blood thinners. So what we do is we put something in there that will actually close it off, that will stop the blood clot from actually developing in that part of the heart. Now, the nice thing about it is years ago, what we used to have to do is take you to surgery. Now, we rarely would do that just for this. We wouldn't just have a first-time surgery going in there just to close it off. But if we were inside your heart for some other reason, whether doing bypass or valve, something like that, we would basically oversew or shut or close off that little small chamber. But now, over the last 3, 4, 5 years now, we've developed a new procedure that we can do through our leg in a minimally invasive manner to put something inside that small chamber of the heart and actually close it off so that you don't develop a blood clot. So that's probably one of the most revolutionary things we've had in medicine, in cardiology over the last few years, because now people who cannot take blood thinners, they're just not sitting there waiting for that stroke to happen. They're able to essentially be able to get a device. They may have to stay on a blood thinner for maybe 30 days at best, but then after that, you can stop the blood thinner and know in your mind that you'll be safe and free of a stroke from atrial fibrillation. So I think a Watchman procedure is an excellent procedure, yes.
Great. All right. So Betty says, got a question for the doctors. People tell you there are symptoms that indicate a heart attack. Is this really true? Does your arm really hurt? Can the doctor share some of the symptoms? And is there anything someone can do to help you until medical assistance arrives?
So, yeah, we can tag team on this one as well. The classic symptoms are sort of a 3-point thing. The feeling of tightness in the middle of the chest, okay, and having discomfort that's occurring mostly at rest. Now, this may have been preceded by a time when you're getting more chest discomfort with exertion, but that would be so-called angina, or if you're from the north, then it's angina, okay? And so, when it starts happening at rest, even though it kind of hurt yesterday to climb the stairs and you quit and you didn't worry about it, and now it's happening in the middle of the night, that would be much more of a heart attack. And yes, that discomfort, because the heart doesn't have its own classic innervation like your finger does, you actually get referred pain. And it would tend to be on the left arm more than any other, on the inner aspect, on the elbow inner side. And the interesting part about it is that it can go to both arms, but it can go to the jaw, it can go to the neck. And that whole description that I just gave you is typical of men, okay? And then women can have it pretty much anywhere. And, you have to be very, very, suspicious when there's a new kind of symptom, anything referable to the chest, and the patients, particularly with risk factors, have a very low threshold to do an electrocardiogram and realize that women will present with an anginal pattern that's a little different. Diabetics do. People who've had bypass surgery will have often, they don't have the classic innervation anymore because it was cut. And so it's possible to have just weird feelings, like a feeling of impending doom. You see that in a lot of you see that in a lot of old textbooks. It's actually true. Getting short of breath, feeling that you're going to have a heart racing, having sweating, the urge to actually defecate, so-called kyphoresis. Those are all symptoms that we should be looking for and have a low threshold for doing EKGs and enzymes to make sure that a person doesn't have the classic signs of a coronary artery that's blocked.
Yeah, I agree. It's exactly right. He's hit on a lot of them, and I think you may have heard from different talks over the years that women don't have those symptoms, and women just have to know their bodies. It can be just fatigue, it can be back pain. But I'll tell you a story. I used to, I still do. I was living on the south side, and one of my neighbors, who's one of the most stoic, mean guys on the block, as mean as could be. But he liked me because I was a doctor on the block, so he would always say, "Hey doc, hey doc." So I'm sitting in my house one night, and I can hear a knocking on my door, and he comes to the door. I said, "Yeah, he won't mind if I say his name, Eddie. Eddie, what are you doing on my door? It's 10 o'clock at night." Well, he comes to my door and he has an empty box of Pepsi. Okay, and he says, "I've been taking this Pepsi for the last all night. I've been taking 30 and 40 of these pills, but yet my belly pain, my gas pain won't go away." And sure enough, after sitting there on my couch trying to convince him to go to the doctor, trying to convince him to allow me to call 911 because it was so short, so mean, just a mean guy. He eventually allowed me to drive him to the hospital. I drove him to the hospital, and sure enough, he was having a heart attack. So I say that to say, and then we ended up putting a stent in his heart, and he did fine after that. But I say that to say is one of the classic masqueraders of heart disease is gas pain. It's just got to be one of the number one things. And first of all, if it's occurring on exertion, it's probably not gas. Number two is that if the acid pills that you're taking, such as Pepsi, Prilosec, or whatever those pills are, or Maalox that you're taking, and it just doesn't quickly go away, it's probably not that. And we need to think that it's probably something more sinister than that. So lots of different symptoms. Know your body. If something's wrong, don't be afraid to go to the hospital. We don't mind. We don't mind. I know it's a pain to go to the emergency room and sit there for hours, but it's better safe than sorry.
Wow. Now, is there anything people can do to help you until medical help gets there? If you have to call an ambulance or something, or is it just rush and get them to the hospital? I'm glad your story ended the way it did, because in my mind, I just kept seeing this guy collapse on your couch, and I'm like, no.
I was worried.
Right. So the most important thing that people can do is to call 911 and make sure that people have equipment. Now, I have an AED in my house. I don't know what I would do with it if I had a problem, but somebody else has a problem in my house, then I can use it on them. But I think everybody should have access to them. The gyms have them. A lot of people will carry one in their trunk. They're not that expensive, and it's important to actually have that capability. Having said that, the most important thing I won't name names, but you probably remember a Chicago police chief who was having a heart attack and drove himself to the hospital. That's exactly not what you want to do. You want to have the ability, because you don't know when the rhythm disturbances that takes you out is actually going to happen. And so the best thing to do is to actually call 911, make it clear that you feel like you're going to have a heart attack. They'll take you seriously. They'll take you to the nearest facility. And we have this thing called door to balloon time. Okay. And if you can get that heart attack from symptom to balloon to be less than 90 minutes, the odds of the muscle having a really bad time and going into heart failure is dramatically lower. So that's what we really aim for, get that artery open as fast as possible.
Wow, awesome. Dorothy Goldsmith asked, endocarditis, I hope I'm pronouncing that properly, is it a condition that goes away? She's asking because of dental care.
Okay, so it's really important to understand that bacterial endocarditis is something that we used to fear a lot for some very simple valve issues, like so-called mitral valve prolapse. The mitral valve is a little bigger. I had an old professor at Emory, J. Willis Hurst, who would tell me, don't tell patients they have mitral valve prolapse, just like telling them that they have big feet. And that actually was very, very true. It turns out that a few years ago, even though I still see people saying, oh, I had mitral valve prolapse and my dentist still gives me antibiotics, the antibiotics are far more dangerous than the risk of getting endocarditis from a dental procedure. Now, that is not the case if you have a lot of leakage of the valve, a lot of serious valve damage, or an artificial valve. Then you actually should be using the antibiotics for the deep cleaning and that sort of thing that the dentists do. Anything that generates bacteria in your bloodstream, you should be covered for.
Okay, Kiva asks, can you all share information about COVID-19 associated cardiac complications? I think we kind of hit some of those.
Yeah, we covered that pretty well.
Did we miss anything? I don't.
Not
Okay.
really. I mean, we didn't talk about rhythm disturbances, which do happen, but that is with any pneumonia type of illness or anything that involves the lungs can really irritate the heart. So you can get a pericarditis, which is inflammation of the lining around the heart, as well as the myocarditis we talked about extensively before. And those can irritate the heart and cause rhythm disturbances. But by the time people get that cardiac MRI or echo, they're usually inpatient anyway. And so we don't have too much trouble following them. They're all being monitored, and we respond to those rhythm disturbances.
Okay. Oh, I'm sorry. Go ahead.
No, I just want to piggyback on what Dr. Hampton was saying earlier. I mean, there are definitely cardiac complications, but there are so many complications that we see. I mean, you can just from head to toe. So the importance of getting that vaccine, and I'm just going to piggyback what Dr. Hampton was saying, and it's just tremendously important to get that. I mean, I know people, have the complications from, not being able to walk 2 blocks, 6 weeks later. So one of my close friends has what we think is from COVID is a foot drop, which is a newer, one of the side effects that, now he's stuck with walking with a cane for the rest of his life. So it's there's so many complications that you just don't know, and we don't know. And so I think it's going to be tremendously important. And I'm sure Dr. Mason would definitely piggyback on that conversation about the importance of the vaccine when it's available.
So we're going to actually have a little vaccine conversation, and we're going to have a little conversation towards the end. We're going to talk about the vaccine and some preventive measures. Just as a reminder, as we talk about every Monday night, we talk about preventive measures, but we have some special things that we want to share about the vaccine, which I think everyone will be really excited about. But Dr. Everett, question for you. The young lady says, Dr. Everett, you shared last week we should be asking our doctors to do a cardiac calcium score test. Are there any family indicators that tell us we should get this test sooner than later?
Yeah, so I think your question was, are there any family indicators? Is that what you asked?
That's what she asked. She said, are there any family indicators that tell us we should get this sooner than later?
Yeah, I mean, the bottom line, essentially what happens is if you have any sort of first degree relative, mother, father, your sister, brother, and, it can extend to grandparents and so forth. If you have any of those relatives,
So I think Dr. Everett froze a little bit. Anybody want to finish this sentence?
that had, you might have lost me. Did you lose me? Yeah.
Yeah,
sorry about that. So, yeah, there we go. First degree relatives, mother, father, sister, brother, grandparents, anything like that, that they've had either early bypass, meaning usually before the age of 65, usually for men and women. So they need bypass surgery, they need a stent. They didn't make it to the hospital. You found them or someone found them and they basically died prior to getting to the hospital. That's usually a sign of some sort of blocked heart arteries. That calcium score, I'm just going to remind you, is basically looking for plaque buildup in the heart. If there's and plaque, when there is plaque, many times it will mature and have calcium in there, and we can fortunately see it because we don't have a special vision, to be able to just look at someone and see that there's plaque in their arteries. So one of the quick and fast ways to do it is to get the calcium score, and then we can take it from there. But in terms of family indicators, yeah, I think that if you have any family history of blocked arteries, early sudden death, didn't make it to the hospital, yes, for sure. But I think that it also extends to people who don't have that. I don't think it's unreasonable. $49 to be able to get, to be able to let you know that, do you have any plaque in your heart artery? I think that's a pretty good deal, in my opinion.
Okay, I agree. Kathleen Jackson asked, is it normal for people to take 3 or more medications for high blood pressure?
So if we're actually seeing that more and more. When you look at that sprint data that I talked about earlier, it went from 2.1 to 3.1 drugs in order to get folks down to the 120 marker. And what we found over the years is surprising, unlike the way we were trained, where you start with a drug and you keep increasing that drug. It turns out that you can avoid more side effects if you take multiple drugs in low doses. You actually have about 5 times more likely to getting a person to their target if you use multiple mechanisms, and you keep the toxicity or the side effects really low if you keep the doses low. So yeah, it's not unusual to be on 3 drugs therapy. It does imply that you're not doing your lifestyle right. And if people, you're, ideal body weight, thin, very little body fat, walking, high potassium in the diet, low sodium, not a lot of alcohol, just the kind of things that we put in our hypertension guidelines. You don't see a lot of people who have to have 3 drugs.
Yeah, but to his point, you can't be afraid of it. You got to get the end has to justify the means. I said, we have to get the blood pressure down at whatever way we can get it. Like we all hear it, all the physicians on the panel hear it all the time. I'm on so many medicines, I can't stand it. I never took any medicines in my life. But, that's why people are doing well. That's why people do well living to 80 and 90 and still playing golf, still playing tennis, because of a lot of times because we've been able to treat their high blood pressure for so many years where they didn't develop the complications that's come from. So don't be afraid of it.
Okay. Our next question says, how can I protect my family and I from my now COVID positive husband?
Dr. Hampton.
We got to keep him separate, but together. It's very difficult, particularly in communities of color where we tend to have a lot of folk that in an enclosed area where you don't always get that in all cultures. So it's difficult to isolate, but you have to find a space for him to exist with you guys. But everybody needs to we have to treat him like he's ill. So we need to make sure wherever he is, he has to have a mask on. And we have to be particularly careful about what we're touching, because a lot of times you don't think about what you're touching or what he touched. So you have to be a little bit more aware. In an ideal state, like I remember when my oldest son traveled and he came back and we kind of tried to separate him. We put him in an environment where he was with one person instead of multiple people. So everybody can't do that. But I think the key is the same things that you would do for anybody, you would do for him. But you just want to make sure that that you're making sure that the rest of the crew is keeping their distance while allowing him to have enough interaction so that he won't feel isolated. So these are basic concepts, but I think I would kind of start there and see if that'll kind of move the needle. It's very difficult, and what I find is that with my patients, it seems like when one person gets it, everybody ends up getting it. So it's very frustrating and scary. And for those who are in the family, being healthy is the best way to protect yourself. So make sure you're taking your vitamin D, but consider vitamin C, consider zinc, and all of those things that you can do to kind of boost your immune system. Make sure you get enough sleep, making sure you're keeping the stress down. Stop. Every time I watch the news, I start having some heart problems, doctors. Literally, I just feel sick. So I stopped watching the news because it makes me sick every
the other
time
thing,
I watch it.
Just to add to Dr. Hampton's point, that to the extent that you can designate a certain bathroom for that person, try to keep that person away from the common areas like living room, dining room. And again, the magic number is that 10 to 14 days of isolation when they're no longer considered to be infective. That's the key. And I mean, it may not be perfect to Dr. Hampton's point. It may be that he's coming in contact with some of the family, but hopefully not all of the family and a limited amount of family. Have his own bath towels, own bathroom, try to keep him as isolated as possible.
Yeah.
Exactly.
He shouldn't be the cook either, right? I mean, it's like
If I
common
could add
sense.
a couple of other little nuggets here. One of the things is that we're dealing with a situation where we do have to make sacrifices for the end, that the end will then justify the mean, which means that, yes, there may be, the individual may feel isolated for a short period of time. We do have to have input with them, but ultimately we want to be able to keep the virus from spreading from one individual to the next one. And in order to do that, we will have to restrict our contact with that individual that's infected. We love him or her. However, it's a necessary evil to be able to be on the other side, and other folks haven't gotten infected, and maybe someone like an older parent or whatever, older relative gotten even serious illness. So we always have to keep that in mind.
You know, that was, you brought up a point that I'm trying to see if I can see that comment here. Linda Johnson stated when you talked about taking your vitamins and staying healthy and your zinc and all of those things. Linda Johnson asked, is sea moss good for the body?
Is what?
Sea moss. I have no idea what sea moss is. None whatsoever.
Sea moss?
Yes.
Yeah.
I know it's a type of
Well, I do know we're getting great sales.
it's a type of algae, and I mean, I can't like rattle all the benefits off the top of my head. I know that from the training I have gotten is that there are some benefits for your immune system. There may be some heart benefit, but just, I can't like give you the specifics. But I think in terms of immune function when I think about that. But it's a type of algae that it's amazing what we eat, right? But I don't have anything else to add to that.
Dr. Sebi talked a lot about it, and he talked about it improving blood flow, reducing inflammation. In fact, he thought it was pretty good for erectile dysfunction. He thought it could put urologists out of business. I don't know about that, Dr. Mason.
I'm on Amazon right now.
I'm sorry, I was sort of preoccupied. I was trying to talking with Farmer Tony. We're going out to try and expand the farming operation. So we had, unfortunately, these meetings overlapped, and we were just trying to get this stuff squared away. So I apologize for not being as attentive. But we're looking at trying to take charge of talking about sea moss. We're talking about how we can create a better sustainable food system where we can get foods that are grown without pesticides and all this other stuff. So we can just eat good food and not have to worry about trying to supplement it with all this other stuff.
So document you on the farm. That's their thing. They try to make all of us farm over here on the west side. He's trying to make us all farm, literally private farm. Imagine me with my stilettos on trying to help them with his garden. He's trying to make all of us farm. And his chickens are still alive. They got chickens. They about to get some goats. I don't know what's going on over there.
I'm not talking about things that eat stuff.
We're not trying to get ghosts, but however we do want to grow plenty of vegetables and one of the things that I remembered, during my years when I was in practice, that I would sit down with a patient that, for instance, had diabetes, or we diagnosed to have diabetes and hypertension, and talk to them about changing, how they live and what they eat and those kinds of things. And most of my patients were not people that were wealthy and could just buy whatever they want whenever they wanted. So they would attempt to do that, to follow the dietary recommendation, and they would eventually come back and tell me, I know you have a good idea, but I just can't afford that. And so what I'm actually, one of the things that I, talked about that I'm trying to do in the community now is to teach people how to grow some vegetable on their own. You don't need, I know we always used to think that you need a lot of acreage to grow, but you can actually grow. And even if you don't have a dirt base, you can do what we call raised beds, where you can make a bed and plant seeds and grow vegetables, and they do well. And it's something that we'd like for people to do that. And it's a lot less. It's a lot less expensive than you trying to go to Whole Food or one of the other places to buy vegetables. Vegetables don't live long. Don't keep long after after they are in the marketplace. So this way, you have them, and they are growing, and you can pick them and use them as you need, and not necessarily buy those that have been picked already a week or two. And so yeah, growing vegetable is something that we want to instruct the people in our community to do more of, because I think it's an end to the mean that we all are trying to get to.
It's a great idea. Half of my backyard is still like that. I seriously, I don't buy any tomatoes or anything like that from the grocery store. I go out my back door into my backyard and pick them and bring them in the house. Thanks to the Millers, that's what I have raised beds and these potted areas, and it works. It actually tastes better. It works great. It's a little work at the beginning. I love it now, but yeah, I don't know what I've let them turn me into, but yes, that's what we're doing. You know, Dr. Pete, we got great information today, right? Let me ask this question that like 5 people have asked really quickly. That question is, does double masking help when you go out into public, wearing 2 masks when you go to like the grocery store or public places? And then we want to talk about the great news that we got today.
Yeah, I think to the extent that you are taking every precaution necessary is good. I don't know that there have been any data to support that wearing 2 masks versus 1 gives you a certain percent more protection. I would say if you can keep that mask on your mouth and your nose as long as possible, especially if you're among a large crowd or amongst people that are in a close proximity, I think that's the key. And again, it depends on what kind of mask you have versus. So if you have on two lessly woven masks, it's probably a good idea. But if you have an N95 mask, I don't think you need to have on 2 N95 masks. You follow what I'm saying? So that would be my suggestion.
Quickly, Steve Robinson is here. He is a great community activist, and he is CEO of Northwestern Austin Council Association. I know he'll fix that when he speaks really quickly, but that's all the words. I don't know if I put it in the right places, but that's all the words that's there. And he's a great community activist. They have a program right now where they have community captives, and they have picked leaders and communities on blocks to help get out great information to the communities of those who can't necessarily around right now, or for those who are in need of information, which I think is very great. And they've done some robust advocacy work on making sure that people were aware of COVID. Am I correct, Steve?
Absolutely. We've been out on a 40-block location, going door to door to approximately 1,500 homes and apartments, handing out PPE, giving COVID-ready information. It took us about 4 months to achieve this, and in the process, we also asked several questions for surveys. Like, how old are you? How long have you been in the community? What are your biggest concerns? Would it be food, housing, job, safety, things of that sort?
Okay, so Steve, share with us that captains. What are some of the information that you want to get out to the communities, and you're using these captains to do it with Because I know a lot of it is based on the pandemic, that we kind of deal with, and that's our issue with healthcare and the disparities, and also the issue with violence in our communities. So, how is the healthcare? How is that going, and how does this work with you sitting here with us today? Kind of share that briefly with us.
Well, as far as the healthcare, um, most of the individuals that we reached out to on our survey, one of the primary things that they noted was a concern of theirs was safety. Healthcare was probably like third or fourth on the list, but this is kind of odd to us because most of the individuals were seniors, and you would think that would be number one. Um, we did encounter three individuals that actually had COVID, and we kind of approached them from the bottom of the stairs, and they didn't open their doors, and we filled out the surveys, by that means. But healthcare and as a pandemic, that's specific COVID, it's a weird scenario because I don't think everyone has enough information. They don't know how to actually create a preventive process, and that's where we got to get more information out to individuals. That's why I talked to you, Nikki, and I was saying maybe we might have to have our own individual COVID watch, seminar, like, and we could bring the leaders in, and then they could disseminate the information to their blocks. Now, as far as violence, I honestly like to look at violence as a pandemic because it's running rampant. Um, the community that we primarily work in, which is the northwest corner of Austin, and I've been part of the Northwest Austin Council for 30 years. I kind of know what's happened in the last 30 years, and I know within those 40 blocks, there are two areas that have always been a violent street or block, and we've been trying to address this by reaching out to those individuals because obviously they are not going anywhere within the last 15 years or more, and we're trying to reach out and tell them, hey, we have to start doing things different. You know, kids are getting hurt, people are getting hurt, properties are being damaged, and we're not going anywhere. And we understand you're not going anywhere, but we have to change what we're doing.
That sounds like a conversation we need to have along with Dr. Jasmine first when we talk about some of the behavioral health issues that happen in our community and how we need to focus on how we can make gains and strides in that. In those surveys, Dr. Pete, one of the issues came up was people not really understanding what quarantining and isolation were. If we can have a brief description of that, that would be great.
Yeah, so isolation was what Dr. Hampton described. So when you have someone that was diagnosed positive for COVID in the family, we should attempt to isolate that person away from the rest of the family. And that doesn't necessarily mean they can never have contact with anyone in the household, but it does mean minimizing that contact. And it does mean having this person to sleep in a different area, to use designated towels and silverware and plates. They don't have free reign of the entire house. That's isolation. Quarantining, of course, is when you are having someone to stay at home and not leaving the home until that 14-day window is up. So those are the two differences. One is staying at home, and one is when you're in the home but you're away from everyone else. Isolation is when you're in the home away from everyone else. The quarantine is when you're in the home and not leaving the home.
All right, thank you so very much. Well, our time is really drawn very near. Johnson & Johnson and Jensen Pharmaceutical Companies have been committed to combating the COVID-19 pandemic through the development of a COVID-19 vaccine candidate. Johnson & Johnson has launched its phase 3, and they're looking for people to be a part of their trials. They have 60,000 positions here in our state for people to be a part of this trial that they're doing. So we want to thank all of these great companies. there's 3 great companies now that actually have come to uh, great strides with us having a vaccine. We may have information before the end of this week about one of them. So, Dr. Pete, if you can just, or any of you here on the panel, if you can just talk about how important vaccine is, how important it may be to be a part of the trial, that would be simply exciting.
Well, I'll just comment that we're all uniquely different, and sometimes as medical folk will call it bio-individuality, and how our genes are made and how they function will vary, not only because of who we are and what our culture is and our ethnicity, but also where we live and the things we've been exposed to. So if you take people of color in general, there are so many things about the stuff we follow in science. Rather, it's like, for example, a lot of people of color have a lower white blood cell count than Caucasian people. And they find that it may not be a big deal. So, but if we don't do studies that help us see these things, then it's impossible for the things that we provide, the medicines, the vaccines, to directly impact us the way we expect it to. So here's an opportunity. This is not a syphilis experiment. There's an opportunity for us to be part of the discussion, to actually create and know that this vaccine will work for not only you, but for the communities that you love and care about. So it's really important that we have to heal from the past. We have to heal from the things that this country has done to us, and it takes time to do that. But while we're healing, we don't want to use fear, false evidence appearing real, as our master, because fear will lead to harm. So it would be very important for anybody listening who has an opportunity to participate in this study. And if you want to look at the other studies, the people are doing fine. So I would encourage anybody listening, not just for humanity's sake, not just for your community's sake, but for your sake, to consider participating in a study like this. I would not hesitate to do it, because the new science, in fact, I think the only reason we have such success with these vaccines is because we're using science that maybe we didn't have the resources for. Clearly, they had it in the back, and they just couldn't use it because they didn't have the money. I think Bill Gates and others have tried to put money towards vaccines, but now we have the resources and the focus. So please consider taking advantage of this opportunity.
Okay.
I just want to echo what Dr. Hampton said. I mean, the reality is we're in a pandemic like we've never seen before since 1918.
Yeah.
And so I would just caution people from standing on the sidelines. Like that's not where we need to be. And as a community, we really do want to make sure that we can get to that herd immunity as quickly as possible. So we have an opportunity to participate in this study. I think it would be great. The other thing, it was my understanding that the National Medical Association has formed that, for those who don't know, that is the African American version of the AMA, that they have a subset of a panel that will be reviewing all of these studies to give their stamp of approval. Now, these are our doctors, who are, many of them are academic scientists, much like this panel, but they're going to be looking to make sure that everyone's done their due diligence in making sure that it is safe and effective. And so I think it's very important that we go ahead and participate in this as quickly as possible.
You know, the one thing that's the double-edged sword here is when we come out with medications and we say, well, how well do they work with Black folks? And if we haven't had Black folks in the trial, we won't know. And not just vaccines, but it was even when we were doing things with erectile dysfunction, prostate cancer therapies, and things of that nature. So we have to be careful, because we can't criticize it because there weren't any Black folks in it if Black folks didn't volunteer to be in it.
Yeah.
And so it's something that we have to sort of deal with, and the minister did convene such that same panel to really look at someone to make sure we're looking at the safety data in a scientific sort of way, not just an emotional right? But people that are also part of the entire process, so that we have people who are involved not only just in trying to recruit people, but and I know Dr. Williams has had a lot of experience looking at data from trials that probably didn't have as many of us in it as we would like to have had.
Doug or Dr. Miller or Dr. Kim,
Yeah.
if you guys want to add to this? Okay, go right ahead, Dr. Miller.
Yeah, I would just add on, add this, with the information that's available to us, we're going to have to spend a lot of time educating the people in our community, because there are individuals who don't have a real understanding of what's going on, but is um, trying to convince the people in the community that that this is, that they should not take the vaccine because of things that have happened in the past, and that this is just simply another part of that same process, and without really understanding what's really going on, and not necessarily understanding what is at stake. So I think that we're going to need to figure out ways that we can better educate the masses in the community. Your patients, we're probably going to be able to do okay with them in terms of having that time that we can give them what we need to give them. But there are a lot of folks that don't have those kinds of connections. And that's where we're going to really need a lot of work. And I don't know, the answer is difficult because obviously there's restriction. We can't bring groups of large groups of people together so we can disseminate this information rapidly. But we're going to have to devise other kinds of measures to do this in an effective way. And I think it's going to be important that people the community trusts give them that information, because that is the beginning of the process. If it's not somebody that they trust, they're not going to really listen. And so we need to figure out how we can do this, and then what means we can do it, even where we can do it. I know in the past, just talking about healthcare in general, there's a couple of times that I was involved with a group of us where we chose different kinds of setting, whether it be, whether it be a church, whether it be in barbershops, and and again, these are difficult things to do in this time, but we do need to look at how we are going to be able to do this better than what we can, what's available to us now, because the studies in at least the surveys that are being done now is talking about maybe 40%, only 40% of Black people are willing to take this vaccine, and that's just not good enough.
All right.
Nikki.
Okay, well, it's that time. Oh, I know, right? It's that time. Well, I want to say a special thank you to Dr. Kim and to Dr. Everett for spending their last 2 Monday nights with us. It has been great. Know that you guys are welcome to come at any time. The door is always open for you. These have been some incredible information that was shared. Heart and what's in your heart. What comes from the heart reaches the heart. So it's very important to take care of that ticker, your heart. We do have your call until next Monday. So what would your thought be until next Monday? What would you like to share with someone until next Monday? So, Steve, what would that nugget be? I'm sorry?
No, I couldn't hear you. Did you say Steve?
Yes, I said Steve.
Oh, I'm sorry. I'm sorry. Can you hear me? Because I'm getting some. It's breaking up. Well, the nugget for me would be to actually get.
I'm answering you, Steve.
The nugget would be to get these leaders that we've already accumulated to kind of go to their blocks and kind of encourage the individuals they have to be involved and take this vaccination. It's important for all of us. And since we've already hit 40 blocks and we have about 28 leaders, we're going to start with them. We'll have our first Zoom meeting with the 28 leaders of our network of neighbors this Thursday. So if any one of you would like to come on and encourage those leaders, feel free to.
Wonderful. Douglas Graham, what's your until next Monday?
Boy, that's a challenge, Nikki. All I can say is we're just going to have to take it easy. It's going to take a long time to get things going and to get things to change. It's not going to be like a video game or on TV. Not going to be done at the end of the hour. So we will have to have a long-term perspective about this. It's going to take time.
Okay. Dr. Your until next Monday.
My would be to hold out and hold on. I know, when, a lot of people got excited when the announcement that the vaccine is going to be there, and that is something to be excited about. However, we still got to get there, and that's going to take some months to get there. So we need to make certain that we continue to do all the mitigations that we've done in the past or been told us that have been told to do in the past, and to hold out, not to just figure down the vaccine. I can just go haywire, because now it's going to be other kinds of surges and problems with the virus. It's just sitting there to be carried, and we need to be vigilant and be patient and hold on.
All right. Dr. Marlon Everett, you're until next Monday.
Yeah, mine until next Monday. Food for thought. I am a COVID survivor, and I do not want to get it again. So I'm going to be first in line. And so, because I am not afraid of it, and you should be afraid of it as well. I was lucky one time. I may not be lucky again. So I really, really implore everyone to let's just eradicate this whole thing and get the vaccine, please. And that's coming from a COVID survivor.
All right. All right. Dr. Tony Hanson, you're until next Monday.
I just want people to, I think I'm echoing what my colleagues, Dr. Graham and Dr. Miller, said in terms of being patient. I know that you have probably 20 million healthcare workers in the country, and they're going to try to make sure those folk are protected because they're on the front line. And you have about 5 million or so in these nursing home facilities. That, so, and I think we don't even have, I think we have probably 40 million doses to get started. So and you have to get 2 doses at least for some of the vaccines. So imagine that. So by the time we get through all the healthcare folk and the nursing home folk, we're probably going to be looking probably all the way through February. And then maybe in March, April or so, we can start hitting the masses. So in other words, the worst part of the winter, I heard the CDC, the guy that leads that, talk about how this may be the worst winter in modern history. So if that's true, for Christmas, I suggest you do what I did, which is I grabbed a meal from my mom at the door with a mask on, and I said, I love you. I said it verbally. I didn't hug, kiss, or any of that stuff. And I think as you plan for Christmas, please make intelligent adult decisions. Do not gather. Let's get through this storm. There will be many more holidays to celebrate. So that's my final word.
Right, right. Dr. Kim, you're until next Monday. What thoughts do you want to leave with the people until next Monday?
So I've actually been hearing a lot from the anti-vaxxers, and I've actually engaged with them instead of ignoring them, trying to find out what are the concerns. I've heard everything from bad outcomes to government conspiracies, and they're out to kill people, which obviously wouldn't make any sense. These companies have to answer. If they don't answer to the public, they answer to their shareholders, and that's going to, short-term versus long-term profits. You can trust that they're on your side, and so, in trying to engage them, I've learned things like, oh, there's aluminum in all the vaccines, and aluminum is an immune enhancer. And so, I try to say, well, what's the LD50? That is the amount of aluminum that would kill half the people. It turns out that you would have to take 70 million doses on the average vaccine. And so I encourage everyone to don't ignore the anti-vaxxers and don't blow them off. Try to engage them with the science. It may not work, but at least you have the science on your side.
Yeah. All right. Dr. Terry Mason, you're until next Monday. Chicken free.
I think everybody said what I was going to say, and I don't think that I need to add anything more to what's already been said.
Okay. All right. Just wanted to hear your voice. Dr. P? Until next Monday.
Until next Monday, just everyone don't ignore the standard infectious control measures. Please continue to social distance, wash your hands, wear your mask. That's our only defense until the vaccine comes out.
So since Dr. Pete told you exactly what we tend to remind you of every Monday, how do we wash those hands? We make sure that we rub them vigorously together with that soap and water, making sure that you get between the fingers, and also in here, don't forget, get the thumbs, get the back of the hands really good. My hands look and feel like leather right now. They really do. They have never felt this way. So make sure you have some moisturizer somewhere around. They're taking a killing, but it's okay. I'm healthy. I'm here. So remember to wash those hands. Also remember the social distance. Spread your arms out, and if you're touching someone and they are touching you, know that they're just a little too close, and politely ask them to move over just a tad bit so you guys can be okay. And also do what? I want you to wear your face covering. We have those face coverings around. Wear your face covering over your nose. Oh, thank you, Doug. Thank you. Thank you, Dr. Pete and Tony. Over your nose and mouth, not on your chin, not over your nose, not just over your mouth, but over your mouth and nose, making sure that it covers both places. Those droplets are what's the danger. So remember, the best way to do this is to make sure that these areas right here are actually covered up. So make sure you wear that face mask over your nose and mouth. Remember, the life you save may be your very own. So until next Monday, right here, same bat time, same bat couch conversations with the doctors. And Doug, Pete and I have kind of forgot that we're supposed to stand up with you. So next Monday, Pete and I will be standing up with you throughout the whole show. We'll be standing up. And we want to invite anybody else to stand up the whole hour along with us for the great circulation that we get. Remember, we got
Let's go, Dr. Mason, Dr. Hampton.
We got to keep stuff moving for our heart. So
stand up.
Remember, next week, see you later. Goodbye. Have a wonderful Monday.
All right.